GoToMeeting thing too? Should I move that down?
Yep, we can only see your PowerPoint.
Oh, okay, great. Okay. All right. So, as you know, today's talk is going to be about muscle MRI. Basically, this is just going to be a basic overview on MRI in general and the use of muscle MRI with regards to diagnosis, potentially prognosis, and potentially as a biomarker in neuromuscular disorders. So what is an MRI? So we all talk about it and hear about it all the time, but I just wanted to kind of review exactly what people get themselves into when they sign up for an MRI. So MRI stands for magnetic resonance imaging. It's a test that uses a magnetic field and pulses of radio wave energy to make pictures of organs and structures within the body. It gives information that's different from an X-ray, ultrasound, or CT scan, where the X-ray primarily focuses on bone, ultrasound focuses on, as we spoke about before, kind of a sound-based image that is limited and doesn't cut through slices and is a little bit more granular in appearance. And CT scan is actually better for bone and blood and calcifications and has higher radiation as well. The MRI is typically used for head and trunk imaging, but recently there has been an effort to use it in muscle imaging. And the procedure involves putting the area of the body being tested into a machine that has a superconducting magnet. This magnet has strength that's measured in units known as Tesla. And this magnet is very dangerous because it is so strong, as you know. And for that reason, they always tell you to take off all of the metal that you have on you that could potentially be attracted to the magnet, because the speed at which it could be attracted to the magnet can actually cause harm to the person who's inside there, and you have no idea in what direction that metal object is going to go, meaning that if you have metal within your body, that metal can actually exit your body during the study, and that's why they have screening procedures that take place. I guess within the neuromuscular community, a lot of the concerns are with regards to scoliosis and surgery for that with rod placement. And for the majority of our patient population, they are of the generation where titanium rods have been used, and titanium rods are safe for use within the MRI. The only problem with that is that it creates some imaging artifact on there, but it does the job, and it's safe for kids to go into the machine with that. So basically, once you enter the machine, you basically enter an area where there's coils and winding wire where electricity is passed through. And these coils, these gradient coils, are superconducting coils, meaning that they're made in a very special way so that they can conduct a lot of electricity at very, very fast rates, so that you don't actually have to use too much electricity, although it's still a lot, to actually generate the energy that you need. And when we're talking about Tesla as the units of the superconducting magnet, Tesla is basically something that you can gauge to understand what the resolution is of the MRI study that you're getting, meaning that the majority of studies today are around 1.5 Tesla, but there are higher resolution scanners that go up to 3 Tesla, and there are some that are going up to 7 Tesla that I think have been used in humans as well. The problem is that when you get too detailed, you can also kind of lose the picture quality as well. So there is a happy medium that we're noticing, and actually 1.5 Tesla is pretty good for imaging muscle. Oops. So how MRI works. So once you're in the MRI, this was a really great picture that I found online that discussed this, and I thought it was a really great way to visualize this. So if you look at box 1 here, so basically the whole human body is chock full of hydrogen atoms because we're made of mostly water and fat. And these hydrogen atoms are what this MRI kind of focuses on the most. And so basically, once put into the magnet, the atoms start to spin in random directions like tops around their individual magnetic fields. And in the magnetic field, the atoms either will line up north or south, meaning some atoms will go towards your head, some will go towards your toes. And about half of, and that's about half of the atoms. But about half are unmatched and don't go in any direction in particular. So then a radio frequency is applied, and that radio frequency is what makes the sound in the MRI, which is a really intense and loud sound. And basically a pulse is applied with that radio frequency, and the unmatched atoms spin the other way. And then when you look at how, when the radio frequency is turned off, the extra atoms then return to their normal position and emit energy. And that energy is basically then converted via a mathematical formula known as the Fourier formula, and it converts into an image. That is what you see in block number 5, which can be MRI of your brain, any MRI of any region of your body. But basically, the gist is that it separates the first round of atoms, and then it basically stimulates a bunch of atoms to go in different directions and then measures the energy that's released. And so different densities of tissue, different qualities of tissue release different levels of energy, and it's that contrast between the different levels of energy that are then transformed into the image that you see. So when you're also talking about MRI, you're going to hear about something known as pulse sequences. One of the pulse sequences is relaxation time. Relaxation time is the time that it takes protons to regain their equilibrium state. And the main determinants of contrast or weighting are 1, repetition time, which is the time between successive radio frequency pulses, and 2, echo time, the time between the arrival of the radio frequency pulse and the arrival of the return signal at the detector. This is a lot of detail, I understand, but it actually will come together shortly once I start talking about the muscle MRI. And there are 2 types of relaxation time. So there's T1 and there's T2. So you'll hear about this in reference to all types of MRIs, but so I'll give you a gist of what it means to be T1 or T2 images. And if you were to get an MRI, for example, and look at it, you can kind of see that they're labeled as such. So T2 is basically longitudinal or parallel to the magnetic field, and it means a short repetition time and a short echo time. And the thing to remember is that on T1, what shows up as dark is dense bone, air, increased water, and inflammation. What shows up as bright is fat, and actually fibrous tissue as well. So in relation to muscle MRI, we do really like T1 sequences because it gives us a really nice image, and we can also tell the degree of fat or fiber infiltration within the muscle because it just shows up as being bright. So we can tell you how much the muscle is involved. Now, it is possible that when you see something as being really bright on the MRI, it might look like the entire piece of the muscle is involved, but it is possible that there's pockets of healthier muscle tissue within, but the image that you're getting is making it look like the entire muscle is involved. That's why it's important to not just look at one slice of an MRI, but to go through successive slices. And I'll tell you about that in just a second. So T2 is basically transverse or perpendicular to the magnetic field, and that's a long relaxed repetition time and a long echo time. So what shows up as dark on T2 is dense bone, air, calcifications, fat and fibrous tissue. And then what shows up as bright is increased water, edema, or inflammation. And fat can show up as white, but less so on T2. So basically, for us, we do prefer to use T1 images to look at the muscle tissue. So just talking about the slices within the MRI, just to review that. So when people lie down for these imaging studies, it's basically that the sequences are generated at certain intervals, which can be 3 milliliters, usually around 3 millimeters. And you look at the images at every single slice, pretty much. But it almost shows like you're scrolling through the entire body, so it's pretty fluid. But basically that generates an image for you that you can view that's almost like taking a piece of salami and cutting it down the middle. So you can basically look at the components of the salami when you slice it. So from outside you just see the outside covering of the salami, but when you cut it, you can actually see the components of the salami. But looking at the components of the salami right in the middle might not be reflective of what's the component of the salami down at the bottom. And it's the same type of thing for legs, which is primarily what we focus on, legs and pelvic muscles, is going through and getting these slices all the way through the legs, up through the thighs and into the pelvis, and taking a look at it not only from a longitudinal view, which is just looking at it from the outside, but also taking these axial or kind of salami slices through and looking at the consistency of the muscle throughout the length of the leg. So other pulse sequences, so stir sequence, this is what's used to suppress fat signal while maintaining water and soft tissue signal. That's a really important study when you're looking at cases of myositis or if you're looking for any kind of active muscle inflammation, meaning that the fat can show up as bright on T1 and, as we mentioned earlier, T2, but less so on T2. So if you were to suppress that fat with the stir, in theory, although it's not 100%, but in theory, if you suppress that fat signal and you maintain water, water, edema are all supposed to be reflections of inflammation. Now, that's not 100% for a lot of cases of diseases, in particular those that have a lot of fibro-fatty replacement, meaning that if you have a patient that comes in with no history of muscle disease but then gets a myositis, which is basically muscle inflammation in the setting of a virus and whatnot, they will have a normal T1 pretty much, but then you go to the stir and you're going to see this area of inflammation. But if you were to take someone who has...
Two wildlife positions that I see that opened up today.
Are you guys hearing me okay? Can you hear me okay?
Yes.
Okay, sorry. So then if you were to take it where you have a patient that has a lot of fat signal in the T1, for example, that fat can sometimes show up even though there is no inflammation in there, and it's a little confusing. And there are some other problems with MRIs that I won't get into, but in all, it's really great to use stir to suppress fat and try to pick up on water, but it's not necessarily the most accurate study to do. So efforts have been made to use additional studies. So one of them is called the 3-point Dixon, which is a powerful way to quantify the individual contributions of fat and water in each voxel of tissue. So they basically assess the chemical shift difference between water and fat, and it encodes images with different echo shifts. So that's being checked out. But again, that has its own limitations as well, meaning that if you were to do a 3-point Dixon, and they do this type of a study sometimes based on how close the leg is to the top of the bore of the MRI machine or to the sides of the bore of the MRI machine, you can have some increased signal there. That's not necessarily due to fat or due to water, but it's due to just technical artifact. So because of that, additional efforts are being made to come up with other sequences that could kind of give you a clear idea of what's fat, what's water, and kind of be able to quantify those, mainly in an effort to be able to follow these changes over time and use them as a reflection of response to therapy. Additional experimental techniques that are used include diffusion-weighted imaging, or DWI, spectroscopy, which looks at the metabolic products within the muscle. Sometimes people use lipid values to assess whether or not there's a lot of fat in that region of the muscle. And magnetic resonance elastography, which is currently being used for liver, but is very similar to the acoustic radiation force imaging that I spoke of with my ultrasound study, where it's essentially an elastography method that hopes to assess the stiffness of the muscle tissue. So MRI and muscle disease. So MRI right now is very great. It's really great for diagnosis. It can help you identify the extent and localization of muscle pathology and provide useful information for the diagnostic workup of patients. Sometimes the pattern of the selected muscle involvement detected by MRI can be almost pathognomonic. It guides genetic testing and it also helps target the muscle that should be biopsied. Now, as you know, I'm a strong proponent of muscle ultrasound, but I will admit that muscle MRI imaging is superior to muscle ultrasound in terms of resolution and detail. The part where muscle MRI fails in my mind is that it takes 40 minutes of sitting still to get good images, and also what is the likelihood of getting a child to stay still inside of a machine like that without sedating them. So if you want to avoid sedation, or if you're dealing with patients that are claustrophobic, I would say ultrasound is fantastic. It can basically also help guide genetic diagnosis and also help target the muscle that should be biopsied. But otherwise, if you have the opportunity and the funds available to do in muscle MRI, I do think that muscle MRI is definitely superior. So additionally, for diagnosis here, semi-quantitative scales and grading have been suggested in an effort to standardize the reading of these images, and I'll talk about that shortly. And T1 weighted axial images, which are the ones that give you slices like going through salami axial, of the pelvic girdle and leg muscles are what have been most frequently described and reported on, though there is an interest in characterizing the various neuromuscular diseases on whole body MRI or upper extremity MRI. So on whole body, you get the added benefit of getting some of the paraspinal muscles, or the muscles that support the spine. You can also get some of the neck muscles and the shoulder muscles, and you would expect that you can get a good view of the arms, but it's actually not the case. Oftentimes the arms are way too far out and go you lose the image in the periphery. So you can only get parts of the arm inside there. Even if you sandbag the arms close to the body, it doesn't work. And then you would think, well, maybe you could put the arms on top of the body. Well, because you're breathing during the study, there's motion artifact from that, and you still can't get good images of the muscle. So that's a really difficult thing. So what people have been trying to develop are some coils that aren't those large bore coils, but they're coils that are specific to going around the limbs. But these are all experimental and probably very, very expensive to buy, which we don't have access to those right now. That's another area where muscle ultrasound actually can be superior as well, because it's really easy to get arm imaging. So talking about other uses of MRI in muscle disease, we hope that you can potentially talk about prognosis, meaning that when you look at it from a diagnostic perspective, you could basically follow it over time and see what the level of change is and how quickly things are changes, and potentially come up with a prognosis, although that's not been clearly identified in the literature, but hopefully in the next few years it will be, once the reads are standardized and more people have muscle MRIs. But the hope is also to get ways of developing sequences that can help measure response to therapeutic intervention, such as for all the gene therapy trials that are coming up, or the other drug trials that are coming up. Ideally, that would be something that it could be used for. Now, the limitations of MRI. So there is varying degrees of muscle involvement that are noted at different stages of disease. And thus the pathognomonic or characteristics of a certain disorder may be more evident early on in the disease. But later on, it might become less distinguishable. That's really been the case in terms of what I've seen, either ultrasound or MRI, is that the longer the disease process has been sitting there for, the more they all start to look the same. So the ideal situation is to catch it early on, probably when the patient is symptomatic, and to take a look at the pattern of muscle involvement before everything has essentially become involved. The other thing is that baseline sex and ethnic differences have not been clearly identified for muscle disease. It's also not clear whether or not a history of exercise influences the localization of muscle pathology, and as I'll show you in the next few slides, certain muscle diseases affect certain muscles, and it's not clear as to why, if it's embryological in nature, or if it has to do with what kind of activities people do, whether or not that influences it. For example, you'll have maybe we had a patient that we saw with LGMD2L, or it's an ANO5 gene mutation or an anoctominopathy, and This was a brother and a sister with the same mutation, but the brother was far more affected than the sister clinically. But when you looked at the MRI, actually the girl who was completely asymptomatic did have muscle involvement, but just in the medial gastrocnemius muscle, the medial calf. Whereas the boy had pretty much most of his calves involved and also most of his hamstrings involved, so much more diffusely involved. So you wonder what is causing this change within the same genetic mutation. Is it because he was a boy and was maybe more active and had more inflammation of his muscle because of all the activities that he was partaking in? Is it because he was a man as opposed to a woman? Did hormones have something to do with it? So these all have to kind of be identified and described a little bit more in detail. Other limitations is that the patient has to lie still for at least 40 minutes per study. In children less than 5, this most often necessitates sedation, and particularly for research studies where the patient has a diagnosis already, I think a lot of parents are hard-pressed to put their kids through sedation to get follow-up studies to see if the child is responding to therapy. So that's one problem there. And also cost. MRIs are really expensive. I think a couple $1,000s each time they run. And so you can imagine how hard it is to get funding for these studies. And it's also difficult to apply standardized individual muscle measurement algorithms, meaning that when you are trying to look at the muscle on the muscle MRI, you would think that there is some kind of a computer algorithm to kind of immediately identify the muscle, measure the area of the muscle, figure out the size for you, but actually no. Most of this analysis is being done by hand with people tracing the muscle for hours and hours at a time. The reason is because even if you were to make a standard template, the standard template kind of shifts between patients, and also you'll notice if there's atrophy of the muscle or if the muscle shrinks at all, it'll actually shift position, so it won't actually be in the same exact place. So it's made it really, really difficult to get volume assessments, and also volume assessments in particular, meaning checking the volume of the muscle from top to bottom. But cross-sectional areas can typically be done relatively easily by tracing it by hand. Right now, if you want to get a muscle assessment, a volume assessment, which is being done by one of my colleagues here at the NIH, she actually had to hire people to do cross-sections at each slice and basically add them all up together to come up with the volume. So you can imagine how time-intensive and tedious that is. But there are people who do it, and they do charge for it. So when you're looking at an MRI in muscle disease, what do you assess? So one thing you start off with is the degree of muscle involvement. Is there atrophy there? Is there fat or fiber replacement? Fat or fiber replacement is often difficult to distinguish from each other on MRI. One thing that is different between fat and fibrous tissue is that fat tends to be softer, fibrous tissues tend to be stiffer. So that's where the MR elastography could be helpful. The location of the muscle involvement is also helpful, meaning is there homogeneous or inhomogeneous changes? Is the whole muscle involved, or is it only in little patches that it's involved? If it's homogeneous, it's more likely myopathic or dystrophic. If it's inhomogeneous, it's most likely neurogenic. And you also want to see if it's anterior or posterior involvement, meaning the top of the thigh or the top of the shin versus the bottom of the thigh or around the calves. That can also help point you towards a specific diagnosis. You want to check for active inflammation as well and see if there's an active destructive process going on. And you also want to look at the subcutaneous fat. Oftentimes, although this is not a hard and fast rule, but this is something that we speak about among each other, myopathic and dystrophic patients tend to have less subcutaneous fat or variable subcutaneous fat, whereas neurogenic patients tend to have more subcutaneous fat and less muscle mass. So findings in various congenital muscle diseases. So here's a list of some of the muscle diseases that have been described in detail. Well, they're congenital muscle diseases that I'm focusing on here that have had MRI descriptions that have been pretty detailed and well recognized. So I'm just going to go through these in detail here. Just to let you know, as I was speaking about standardizing it before, this is one of the grading scales that's been used to describe the muscle MRI. 0 being normal, 1 meaning moth-eaten appearance with scattered small areas of increased signal. So increased signal meaning the brighter areas that are either correlating with fat or fibrous tissue. 2A means late moth-eaten appearance with numerous discrete areas of increased signal with beginning confluence comprising less than 30% of the volume of the individual muscle. 2B is late moth-eaten appearance with numerous discrete areas of increased signal with beginning confluence comprising 30 to 60%. 3 is a washed out appearance, fuzzy appearance due to confluent areas of increased signal, so the whole muscle starts to look white or bright. And then 4 is end-stage appearance, muscle replaced by increased density of connective tissue and fat with only a rim of fascia and neurovascular tissue distinguishable. So that's when it gets really hard to use MRI as a diagnostic measure. When you're at grade 4, and maybe even at grade 3, but around grade 1, 2A, 2B, you should be able to use it as a means to come up with, or at least help you come up with a diagnosis for muscle disease. So let's talk about RYR1 or central core disease. So there's a lot of detail about each of these individual diseases, but I'll just give you a brief overview. So central core disease come in autosomal dominant or recessive types. Which can have different clinical presentations. They might be associated with eye movement abnormalities and often have something called malignant hyperthermia or an adverse response to anesthesia being administered. And these are the characteristic involvements of the muscle tissue. So this is the actual MRI that's being shown. This is a T1 image, and this is a schematic of or a drawing of the pattern that has been recognized. So basically here, and this is from a Treat NMD consensus statement paper, which I found to be very informative. Although more information can be provided, I think, and hopefully I can gather some of this information while I'm completing my fellowship here to kind of put it all together. So looking here, so here we have on this side here, we have the thigh, here we have the calf, okay, just to orient you. Here's the femur, here's the tibia and the fibula. And this is actually the left leg. This is the inner part of the leg. This is the outer part of the leg. This is the rectus femoris muscle here. This is one of the quad muscles. The quad is composed of vastus lateralis, vastus intermedius, vastus medialis, and the rectus femoris. And in comparison to the other muscles of the quadricep, you can see that this rectus femoris muscle is spared. On this schematic, the sparing of the muscle is designated as being in black. The more involved muscle is designated as being white. So here we see some rectus femoris sparing. Then going on to here, this is the sartorius muscle, this is the gracilis muscle, this is the adductor longus, this is the adductor magnus. So here we see that this sartorius muscle is a bit more involved than the gracilis. This can be a distinguishing characteristic. You can see that the adductor longus is spared compared to the adductor magnus, which is also a distinguishing characteristic. The hamstrings are kind of what I would call mildly involved here, which is designated by this color here, this gray. So then going on to the lower leg, we can see that this is the tibialis anterior, extensor digitorum longus, peroneus, tibialis posterior. These all look pretty good and they look almost spared. But then we have involvement of the soleus, which again correlates with this white part here, and some mild involvement of the gastrocnemius muscles, although it's not too bad. So what I would take away from this is that the key features of an RYR1 or central core disease patient is that this is a rectus femoris sparing type of disease on muscle MRI. You can also see this on muscle ultrasound, okay? The sartorius is a bit more involved, the adductor longus is spared, and the adductor magnus is more involved. The soleus is also more involved. Now this is not a hard and fast rule by any means, but it's something to guide you by, particularly the fact that there is rectus femoris sparing. But now just to blow your mind, go on to CEPID 1, And you have rectus femoris sparing here too. So that's really confusing because it's very similar. But there's actually more involvement of the quadriceps, so it's not as obviously spared. But again, you have a very similar picture here. Sartorius is more involved than gracilis. Adductor longus is more involved than adductor magnus. Less involved than adductor magnus. There is something that's unique here, where this semimembranosus muscle tends to be more spared than semitendinosus and biceps femoris muscle. But again, oh, sorry, I moved it over. But again, this is not something that's clearly distinguishable in all cases. One thing that we do pay attention to, in particular in SEPN1 cases, is this fact that there is sartorius involvement more so than gracilis involvement, this adductor longus sparing. But again, it's very difficult to distinguish this from RYR1. What you have to do is take this image into consideration with the clinical picture. So a SEPN1 patient typically looks pretty different from an RYR1 patient. So just based on imaging alone, I could tell you that it is difficult to distinguish these two, just looking back at it. Because again, even though this one has more white here and more white here, and this is more gray, that's not a hard and fast rule. These are just kind of guidelines of what to look for in terms of the pattern. So there is cases where it's pretty much all white in SEPN1 as well, and it could be gray here in RYR1. But the key thing to take into consideration is that you have to look at these images with the clinical picture in mind. An additional thing is that the sternocleidomastoid muscles in patients with SEPN1 or rigid spine disease tend to be more involved than in RYR1 patients or central core disease. So that's one distinguishing feature, and the only way that you can actually pick up on that is if you were to do a whole body MRI. But the SEPN1 patients, again, have a different clinical picture, and just to review, because I was telling you about the RYR1 patients, SEPN1 typically does not have ophthalmoplegia or limitations in eye movements. They do get early scoliosis and can have some respiratory difficulties, which are not necessarily prevalent in the RYR1 population. And they also have a characteristic face where they have something that looks like a tubular nose that you don't necessarily see in the RYR1 patient population. But again, these are not hard and fast rules, but this is typically what we do see. Oh, and then they have a rigid spine, obviously. So moving on, so collagen 6 myopathies, which are also known as Ulrich or BETHLEM myopathy, have a very distinguishing phenotype. Basically, I've seen this in all patients except really, really end-stage patients, and there has been only one patient that I have seen to date that has had this type of an MRI but has been negative for collagen 6 myopathy. But that's actually a really good percentage because we see a lot of collagen 6 patients here because Carson does a lot of research on collagen 6. But the unique finding here in this disorder, just to review, collagen 6 myopathies involve primarily proximal muscle weakness or weakness in the muscles closer to the trunk, and also contractures at the elbows, knees, or ankles, some skin changes, which are keloid scarring and keratosis pilaris, which are those bumps that you can sometimes get on your upper arm, and also a distal hyperlaxity, meaning that your fingertips can kind of bend up a little bit more than usual. Taking that whole clinical picture into consideration, you throw on there or stick the kiddo in an MRI, and if you were to see this finding right here, which is a central cloud inside of the rectus femoris muscle, that's pathognomonic right there. But you can also see additional findings which involve rimming of the muscle, meaning if you look here, oops, I lost my mouse here. If you look here at the vastus lateralis, you can see a rim. Now, each muscle is covered in a layer of fascia, okay? The fascia is similar to, like, for example, if you were cutting through chicken, it's like that thin layer that kind of compartmentalizes the meat. And basically, collagen 6 is a disorder of the extracellular matrix. So this disorder tends to affect the muscle from the outside in along the fascial boundaries. Now you say, why is there something such as a central cloud within the rectus femoris muscle? Well, the rectus femoris muscle is something known as a bipennate muscle. And a bipennate muscle means it's kind of divided longitudinally by a big long line of fascia So this is, again, following the rules of the collagen 6 disorder, meaning that this problem with the muscle is actually stemming out from the fascial plane within the rectus femoris muscle itself. So we're getting it from the outside in, the outside fascial layer, and also from the inside fascial layer there. You don't have that type of bipinnate distribution within the rest of the muscles in the leg here. The same is the case down here. I have seen rimming in the gastrocnemius muscles. I've seen rimming in the tibialis anterior muscle. There is a fascial plane here in the tibialis anterior muscle. I've seen a similar type of appearance there, where the fibrofatty replacement within the muscle tissue starts to come out right from there. Okay, moving along. More has been described about centronuclear myopathies, particularly a DNM2 mutation, which is a specific type of gene mutation. Centronuclear myopathies are basically named that because of the finding on their muscle biopsy where all of the nuclei of the muscle cells tend to move to the center, whereas at baseline they tend to be on the periphery. And these patients typically present with some mild facial weakness. They also have ptosis, which is the drooping of the eyelids, and might have proximal or distal weakness. The pathognomonic findings here in the centronuclear myopathy is that there is more distal, meaning the lower part of the leg involvement, than proximal involvement. And it tends to affect the muscles that are posterior more so than the anterior muscles. There has also been some suggestion, which is not described in this paper here, that the rectus is, well, actually it is subtly described here, but you can't actually see it on this image. And I have to be honest, this has been a description, and it's not something that I have necessarily witnessed. So a lot of this stuff is just something that someone's seen and they've passed along. It's almost like an urban legend until it's been published in a great study. But it's not something that I've necessarily seen clearly on a regular basis. But basically, it's the reverse of the RYR1 patients. So the RYR1 patients, or the central core patients, had rectus femoris sparing. And here, there tends to be a little bit more involvement of the rectus femoris than the other muscles. And also, you have to just take into consideration that the distal muscles are more involved, and in the hamstrings there appears to be some sparing of the semitendinosus muscle. But again, this can be variable as well, and these are just guidelines. So there's also subdescriptions about EMERY-DREIFUSS muscular dystrophy associated with the LMNA gene. So basically these are patients that have a typical appearance of proximal weakness, contractures, and conduction abnormalities in the heart, and one of their major causes of death is related to heart disease. So here what you can see is that, again, there is some rectus femoris sparing, but the sartorius muscle is not as involved as the gracilis muscle, not more involved than the gracilis. So this is unique to this condition as compared to both SEPIN1 or rigid spine and also RYR1 or central core. So that's important to remember. But basically it seems like the more lateral muscles are more involved, and the vastus intermedius. So vastus intermedius and vastus lateralis are more involved, and then there's some mild involvement of the posterior muscles of the leg, of the thigh, and there's also some mild to moderate involvement of the posterior muscles of the lower leg. They also mention that the medial gastrocnemius muscle is more involved than the lateral gastrocnemius muscle, and to be honest, this is not the only disorder where this is the case. This happens in a good number of diseases, and there's probably something about the medial gastrocnemius muscle that leaves it more susceptible to changes than the lateral gastroc, but it hasn't been described. But I'm convinced that it's probably something embryological. And these are things that we less frequently encounter, but this was also described in that paper, which is LGMD 2D or alpha-sarcoglycanopathy. This is kind of in the family of the muscular dystrophies, like the Duchenne muscular dystrophies. So basically, if you look at the muscle here, you can see that the posterior muscles are the hamstrings, and the adductor Magnus are all involved with fibrofatty changes, and they're actually all really small and atrophic. It's more like scar tissue. The vastus intermedius is also involved, the rectus femoris, the sartorius, and the gracilis, and the vastus lateralis are all pretty mildly involved, and the distal muscles tend to be okay. Now the interesting part here is that if you look at the muscles in this LGMD2D and also in Duchenne muscular dystrophy patients, these muscles to me, and this hasn't necessarily been described formally, but this is just an impression that I have, tend to look more swollen. So take a look at this sartorius and gracilis muscle. Compare it to the sartorius and gracilis muscle in the EMERY-DREIFUSS, CENTRONUCLEAR, collagen 6, SEPM1, RYR1. And then focus on that area and now look at the size of those inside of this sarcoglycanopathy. I've seen this in Duchenne patients as well. And the same is the case for this region, vastus lateralis. They all kind of get atrophic and smaller than the other diseases, whereas in the sarcoglycanopathies and muscular dystrophies, they tend to get, other muscular dystrophies, they tend to get a lot bigger and kind of swollen in appearance. And I wonder if that's something related to the inflammation component of it. LGMD2I is a fukutin-related protein disorder. This is also along in the LGMD family. Not necessarily the same type of swelling that we saw with the alpha-sarcoglycan. I kind of grouped the phenotype of the alpha-sarcoglycans to be very similar to the Duchenne patients. The fucutins are a little different. But here you can see that this has more specific involvement of the adductor magnus muscle. Here they say that there's some sparing of the adductor longus, but here you can see it's involved. Sartorius and gracilis are said to be more spared. Rectus is supposed to be spared here, but you can see that the vastus medialis is involved and the vastus lateralis is more spared. And then distally you see more involvement of the gastrocnemius and the soleus muscles. Anectominopathy is LGMD2L, which is what I was speaking about earlier with the difference between the boy and the girl patients. So their characteristic findings, which has been actually something that I've seen, is that the medial gastrocnemius muscle tends to be more involved than the lateral gastrocnemius muscle. Soleus is very involved, and you also see involvement of the hamstrings, sparing of the short head of the biceps femoris muscle, and also sparing of the sartorius and gracilis muscles, and actually some sparing of the rectus femoris muscle as well. These patients can be pretty mildly symptomatic to having some difficulty with, for example, going up on their toes when they're walking, and I've seen the whole gamut where they have no symptoms at all, maybe some fatigue, to not being able to go up on their toes and having a bit of a waddling gait, to being wheelchair bound. And then there's myofibrillar myopathy. So they come in different flavors in terms of clinical presentation. So they're one of the, here they focused on a number of the different types of accumulations that you can see, or different types of myofibrillar myopathies and the patterns that you can see with them. These are pretty rare. I've actually only once seen a case, and it's not described here, actually with Anne in San Diego. That was like the first myofibrillar myopathy, but these are pretty rare, and these have also been described in that paper, but I don't need to go through the detail about that here because it starts to get to be a little confusing comparing it to everything else. And then the other one that's really interesting is Pompe's disease. So Pompe's is basically a glycogen storage disease, and that has some characteristic findings on muscle MRI. And basically, they present myopathy, which could be their initial presentation. But as adults, they can sometimes just present with muscle stiffness and difficulty with breathing. And if you do an EMG on them, you can see myotonic discharges, which are basically kind of dive bomber sounding electrical discharges that are elicited by the muscle when you stick a needle inside there, which are characteristic for both Pompe, some of the other myotonia conditions, and also myotonic dystrophy. Myotonia conditions being like paramyotonia congenita, myotonia congenita. And basically here you can see that it's more posterior than anterior involvement of the muscle, and it's more proximal in the thigh than it is distal. So currently we're working on trying to describe more of the findings of titinopathy. So we have some of the patients with titin mutations coming to the NIH to undergo MRI studies so we can better characterize this condition and also hopefully spread the word on what you should be looking for on muscle MRI when you're working up these kids. And we're also going to try to see if we can follow changes over time potentially. And we do need to get more data on NMLN patients as well. That would be really useful in trying to characterize the muscle involvement in these disorders. And these were kind of spoken of in that Treat NMD consortium, which was basically a group of European neuromuscular docs who got together and spoke about their experience with muscle MRI. But they did not have any schematics or diagrams kind of showing what you should be looking for with these two conditions. So obviously the more the merrier. The good thing about the NIH is that we have access to a lot of these MRI resources here and can get beautiful quality images that we can hopefully put together. And that's about it. Thank you so much.
Wow, that was great, Naz. Thank you.
You're welcome.
Anybody have any questions?
I actually have a couple of questions. First of all, thank you so much for the presentation. It was wonderful. And if I understand correctly, you have yet to characterize any NMLN muscle. Is that right?
So there have been like just case reports within the literature, but nothing that's been like a large quantity of patients.
Okay.
That have been actually graded. So I'm really particular about how we read these MRIs, and I would like to consistently grade them according to the standard that I listed earlier. Where is this here? Because you'd be surprised, a lot of times these MRIs get done and they get read by musculoskeletal radiologists who focus mostly on muscle MRI for myositis. So they'll say there's no evidence of inflammation or there's fatty replacement and inflammation, but nobody's giving any of these a score. Nobody's really describing these in details, and it's actually been a lot of the neurologists that have been, or the neuromuscular specialists that have been doing this. So one, I think it needs to be consistently described in a muscle grading scale, and two, we have a person who has his own scale at Johns Hopkins who's collaborating with us to describe this even further for us according to his scale, so we're going to try to see which one is a bit more sensitive. And in theory, even though this is kind of a subjective measurement, it is given a number and we could potentially follow that over time and also see what muscles are more involved than others and come up with one of these schematics as well, which I think is really useful in terms of trying to figure out these patterns when you look at these muscle MRIs.
Okay. And then another question. When you were talking about Col6-related myopathy, you said that KP is associated with that subtype?
Keratosis pilaris?
Right. Is that associated with other subtypes of myopathy as well?
I've seen it in other patients with myopathies as well. Yep.
It
could be a totally... I would say that the way I would approach it is that if your kid has distal hyperlaxity, proximal weakness, contractures, and keratosis pilaris, then it's almost and some keloid, it's almost a slam dunk that they have collagen 6. But keratosis pilaris alone doesn't mean anything in particular. But if you had a patient with myopathy and contractures and keratosis pilaris, then it would be something interesting to look into. But then again, I would look for the distal hyperlaxity. Like there's a huge number of the population has keratosis pilaris. Like for example, I even have keratosis pilaris. I'm sure other people in the crowd here have keratosis pilaris on their arms, which are just those fine kind of sometimes erythematous bumps on your upper arms and maybe on your thighs. But it's good to know if it's there. It kind of helps seal the diagnosis, but it's not necessarily specific to collagen 6.
Okay, I was just curious if there was some sort of a connection between what's going on with the myopathy and then having this skin condition too.
Yeah, no, I think it's a really good question. I've actually thought about that myself, but I haven't looked into it to see why that might be the case. But often it's associated with collagen issues, but why, but it's not necessarily a collagen 6 type of disorder only. But why it would be the case in other, I've also seen kids with, for example, even with cerebral palsy who are in a wheelchair all the time have keratosis pilaris, and I don't know what that's attributable to. You wonder sometimes if it's related to immobility, not getting a lot of sun. Sometimes there's been dermatologists that have said that if you take a lot of vitamin D, that can help it go away. But I think that the etiology isn't 100% clear, at least as far as I know. And so it's not something that I could definitely say points to anything in particular. But again, it's an interesting thing to note when you're thinking of a differential diagnosis, but it's not necessarily specific for the disease.
Okay. I was just curious because I've, known that KP is prevalent just in the population in general, and I haven't really heard anyone make that connection between having KP and having a specific subtype of myopathy. So I just wanted to better understand what that connection was.
Yeah,
okay, well, thank you.
Something, if you come, it's something that we just take note of in these, and I think that I probably have a good grasp of this just because Karsten, who I work with, focuses a lot of his energy on collagen 6 disorders, and it's something that's really common in the population.
Okay. Thank you.
No problem.
Naz, I'm a genetic counselor at the University of Missouri. I have a quick question. So we have some patients that have had muscle MRIs, but I think our radiologists are A, not comfortable really reading them, and B, probably have really no idea what they're looking for. So in those cases, would you be willing to read MRIs for patients?
Yeah, for sure. I mean, we'd be willing to take a look at them for you. It's not a problem at all, and just offering an opinion. And I often look at them with Carson, and then we can give you a differential based on that. But if you give us a clinical history in conjunction with that, like for example, like how I was showing you with the SEPN1 patients and the RYR1 patients, it's good to know the clinical history, and we can kind of point you in the right direction.
Sure.
Yeah, obviously that's yeah, we do that with Anne sometimes for some of her patients as well.
Oh, good. Okay, great. Thank you.
Naz, this is Sabine. I have another question. How many patients do you have of each subtype for these MRI studies?
For these MRI studies. So I would have to go through my list, but I can tell you that I have, right now, I have for collagen 6, I think I have about 20 MRIs so far. For LAMA 2, it's around 20 after this year. But actually, we are sharing this data with the University of Florida, where they're doing all of the data analysis on it. Because we don't need to really describe the phenotype or what it looks like on the MRI, because it's already been fairly well described for these disorders. But what we are having them do is do an extra analysis on the muscle tissue, which is with that 3-point Dixon to separate water from fat, and also do some spectroscopy to look at the metabolic breakdown. But for the rest of the disorders, I would say I have about 5 of like RYR1 patients, 2 for SEPN1. I would have to say CENTRONUCLEAR I have 2. These are all pretty rare disorders, unfortunately, so it's hard to get a hold of like a lot of patients.
Right. So I have another question. I don't want to interrupt.
Not at all.
Many of these diseases or conditions are progressive, no?
Right. Yep.
We get the same picture of, spared muscles and, muscle that's wasting, or could you see a correlation between onset of the disease and the time where you took the picture, where you did the MRI?
Yeah, so that's one of our goals, is to correlate what we see on MRI with the motor function testing that we do on all of the patients that come here, and to see if there is a correlation between that. So the motor function testing could be either standard PT assessments, or it could be myometry for strength assessments. And we're also correlating it to my muscle ultrasound to check the stiffness of them, where I have that software that checks the stiffness. We're going to correlate the muscle MRI findings to that. So we're trying to see if it actually is something that could be followed over time. Oftentimes, I think preliminarily, see, I don't know how much I'm supposed to talk about this, but I think that basically This is not my data. This is from the University of Florida. I think that what they have been seeing is that the year to year, the collagen 6 patients do not decline in terms of the MRI analysis as much as Duchenne patients tend to. So it speaks to the nature of the disease as well. So yeah, so there's definitely things that you can follow over time and see how it changes over time. But I think that's still within the collagen 6 patients and probably most myopathy patients overall, there has to be more sensitive measurements, for example, like the tissue stiffness, to assess like how they're changing over time and whether or not that correlates with motor function.
All right, thank you.
Naz, I have one more question. This is
Sure.
Sarah again. So how young are you doing muscle MRIs on patients? Like in infants, in toddlers, in adolescents? What?
Yeah, so that's a great question. So basically, we can, here at the NIH, we can do MRIs under sedation if it's helpful for a diagnostic workup in someone who's undiagnosed.
Sure, we do plenty of our MRIs under sedation. So, I mean,
but so long as they have a diagnosis, we are not allowed to sedate them. So if they already have a genetic diagnosis, we can't. Exactly. They say that the risk does not outweigh the benefit.
Right, of course. Okay, so if I had a patient here that, you know, we couldn't diagnose and, you know, was an infant, needed to be sedated, that would still be readable data. You know, that MRI would still provide something.
Now, it could potentially. I'm gonna tell you something about infant muscle. That's a little hard. So, what's my experience with reading infant MRI? It's very, very little. Okay. But I do look at infant muscle ultrasound, and I have looked at infant muscle biopsies. And the problem with infant muscle is that the fibers tend to be really small, and they're not fully developed yet. And in that setting, you could imagine that each fiber that composes a fiber each fiber that you can see on a muscle biopsy, for example, has a paramecium around it. And the smaller the muscle fibers are in size, there's like more of a density of this paramecial tissue to actual muscle tissue, if that makes any sense.
Yeah.
So, because they're so small, because the muscle fiber hasn't grown much. So I've noticed that, especially on muscle ultrasound, that there's increased echogenicity, which can sometimes correlate with myopathic changes in these kids, even if they don't have muscle disease. But I think it's related to the higher ratio of paramecial tissue to muscle fiber volume. And as you get as you get older, you get more muscle fiber, and so that paramecial tissue kind of spreads out.
Sure.
And then you could get a better look at the structure of the muscle without getting kind of fooled by these kind of false positive things. But I think that that's part of it. And it's the same is the case, unfortunately, with muscle biopsy in kids under the age of 2. Getting muscle biopsies on kids under the age of 2 can be very, very difficult to interpret. So, you know, for pretty much the same reason, you can't tell what's, you know, if there's fiber size variation, you can't really get a good idea about the mitochondria. You know, you can't tell if the fibers are small or if they're, you know, there are standard measurements for some, but it's still really hard to read. I think the only thing that I've seen that has been very easy to read, not easy, but can be picked up on in muscle biopsy in kids under the age of 2 is like centronuclear myopathy.
Yeah, that would have been my guess too. Yeah.
But otherwise, you haven't had the time to develop the damage that's necessary to be able to pick up on these pathognomonic changes also.
Right. Okay. Thank you.
In follow-up to that question, this is Stacy again. So if families are interested in having ultrasound or MRI studies done, and they have infants or toddlers, should we be recommending to them that they wait until a certain age before they pursue this? with their children?
So that's a really great question. So I would say, again, I really think I think it would be difficult to, you know, it's a good question. I've actually posited it. I haven't thought about it that much, and I could talk to Karsten more and get back to you on this. But I would think that I would be hard-pressed to balance the value of putting a kiddo under sedation for an MRI as an infant as compared to the risk of putting them under sedation. Now, I mean, sedation procedures are very good these days, so I could see it being very useful, but I haven't had enough experience or seen much in the literature about muscle MRI in infants to tell you the usefulness of it. What I can speak to is the muscle ultrasound. So right now there is a fellow who has been working here who has been performing muscle ultrasound on infants without muscle disease. So she's just going into nurseries and doing muscle ultrasounds on these infants. And she's going to be putting her data together. But it's an area that's lacking in information for sure. And it's very difficult to get as well because, as you can imagine, infants have a lot of subcutaneous fat to go through. They're super pudgy, and it's hard to get a good visualization of the muscle. Additionally, they tend to move a lot, and it's hard to steady them. So it's hard to get a good view. But I have noticed that over the age of 2, you can get really nice images. But under the age of 2, I would have to say that I'm lacking in experience and in data to tell you if it's worthwhile to pursue.
Okay. So maybe we should be suggesting to families wait until your child is over 2.
Yeah, I mean,
sounds like to me.
Yeah, I mean, nothing has been clearly described in the literature yet, so you could potentially get the MRI, but then interpreting it will be difficult. I would say if a kiddo is being sedated for something else and they're already in the machine, you know, why not just add a few extra sequence? Go ahead and do it. Why not? Yeah. Unfortunately, we can't get that kind of data here at the NIH because we're prohibited from doing under 2-year-olds here. So, you can imagine how hard it is to get on kids, because also the other issue is that a lot of these symptoms don't necessarily show their faces until later in the disease course. What you might get in the neonatal setting is SMA, some of the metabolic myopathies like phosphofructokinase deficiency, for example, POMPE, or you'll get myotubular myopathy, CENTRONUCLEAR myopathy. But what is the likelihood of that being presented in a NICU altogether, let alone having a neonatologist who's interested in working it up from a muscle MRI perspective? So, I mean, these are all fortunately, rare diseases, but because of that, it's unfortunate that because of that, we don't have a lot of data to assess them that well.
Okay.
Yeah, I was going to say, like, for example, like in my neonatal, I did a full-on neurology fellowship, and I had pretty much about 3 months of neonatal neurology experience. And in that time, I saw one kid with phosphofructokinase deficiency and a set of twins with myotonic dystrophy. And that was pretty much it for muscle diseases that I was exposed to in that 3-month period in a tertiary care center, which had very, very high volume patients. So these are all such rare disorders that it's hard. But if we get the word out there, and if they're going, I mean, these kids have more central nervous system issues when they're born in the NICU, and oftentimes you can actually wrap them up and just papoose them and put them in the MRI, and they don't even move, right? So it would be great to actually tell people to go ahead and get MRIs on these, at least these NICU babies. I would think that the 1-year-olds are probably the hardest, or, you know, starting from 6 months on when they start to move a lot. But I would think it would be a really great effort to try to pick up on the changes in the muscle in this really early age group.
Okay, thank you.
Any other questions? Okay. Thank you so much, Naz.
Oh, my pleasure. Yeah, thanks for the questions. I'll look into the the interest level for trying to get MRIs done. I have some colleagues that are neonatologists who are interested in muscle disease, and to see what the likelihood is of trying to get these kids with either hypotonia or severe weakness into into MRI machines, to see how that works out. I'm not sure how it's going to work out because of size. Oftentimes these sequences are really standardized, so it'll be interesting to see how that could potentially work out. But I think it's a really great idea to try to pursue that population of patients, and I actually wasn't thinking about it. So.
Great. All right. Well, thank you.
Okay, thanks so much. And if you ever want to send any images for review, you can just email me. I can either give you my email or Rachel can send out my email. And I could share it with Karsten, and sometimes just a little bit of a clinical history would be helpful. And we could try
that
to
would be wonderful. Thank you so much.
Yep, no problem.
Okay.
All right, take care.
You too.
Bye-bye, everyone.
Okay.